broadcasting from two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare podcast. This is our episode number 86. And today I'm joined by my co-host, Dr. Jose Checco. So welcome, Dr. Checco.
Hi, good evening. Good to be back again.
Yeah, absolutely. And I guess the things are settling down slowly. So it's good to be back and get the weekly episodes out again. Now, last week we covered interesting randomized controlled trial, which was published in Intensive Care Medicine, which was called as controlling study. And that trial tested the efficacy of individualized glycemic control based on HbA1c levels versus the conventional glucose control strategy. And that trial was stopped early, did not show any mortality benefit with individualized glycemic control. So we thought it's quite timely to cover the whole debate or a whole controversy around the glycemic control in ICU in general. So today we are going to dive into the glycemic control strategies and what are the different aspects of this controversy. So the first to start with a bit of a context to this whole episode. As we know, glycemic control is quite important in intensive care patients because either hyperglycemia or hypoglycemia can be very harmful to ICU patients. And that's based on the physiological data where high glucose levels might lead to impaired immune response secondary to abnormal glycosylation of immunoglobulins. Also, it might impair neutrophil migration and suppress the phagocytic activity, complement fixation, and bacterial opsonization. So overall, high glucose level will affect the immunity and will lead to increased chances of infection complications. While on the contrary, if you try to maintain the glycemic control too tightly, then that will lead to more frequent hypoglycemic episodes, which will have significant impact on neurological recovery. So either way, glycemic control is challenging. However, what we don't know so far is what's the ideal range of blood sugar levels in critically ill patients. Now, the glucose management in the intensive care unit has been a matter of debate almost 2 decades. And it started with some of the landmark trials which came from Leuven by Vandenberg. And then subsequently, there was a landmark publication of nice sugar trial from ANZIC CTG group. So before we dive deeper into different aspects of glycemic control controversy, Dr. Checco, can you please summarize the evidence obtained from these 3 landmark trials and what are the kind of key findings from this trial?
So we'll start with the Leuven-1 trial, which is one of the earliest studies on glycemic control in critically ill patients. This was from a surgical intensive care unit at the Catholic University of Leuven in Belgium. In this randomized controlled trial, patients were randomized to intensive insulin therapy to maintain a blood glucose level between 80 to 110 milligrams per deciliter in the intervention arm. And in the conventional or control, insulin infusion was commenced if the blood glucose level was higher than 215 milligrams per deciliter, and the levels were maintained between 180 to 200 milligrams per deciliter. They studied 1,548 patients, and they showed that ICU mortality was significantly lower with intensive insulin therapy or diet control versus the conventional group, which aimed for a level between 180 to 200 milligrams per deciliter. The difference in mortality was predominantly evident in patients who had a duration of ICU stay of more than 5 days, with the greatest mortality reduction observed in patients with a septic focus and with multi-organ failure. Furthermore, intensive insulin therapy reduced the overall hospital mortality, reduced the incidence of bloodstream infections, acute kidney injury, and requirement for renal replacement therapy was less with the intensive insulin regime, intensive glucose control regime. The number of red cell transfusions and the incidence of critical illness polyneuropathy were also lower with intensive glucose control. the requirement for long mechanical ventilation and intensive care. The LUEN-2 trial was on medical patients. So the previous LUEN-1 trial, as we discussed, had shown benefit among surgical ICU patients. So the question arose, could the beneficial effects of intensive insulin therapy be replicated in a medical intensive care unit? So this study in medical ICUs involved 1,200 patients admitted to the medical intensive care unit, and they aimed for a glycemic target very similar to the LUEN-1 trial that I mentioned previously. However, in this RCT, the in-hospital mortality was not significantly different between intensive versus conventional therapy groups. It was 37.3 versus 40%, and the difference was not statistically significant. The incidence of acute kidney injury was lower with intensive insulin therapy. Besides, the time to weaning from mechanical ventilation, the duration of stay in ICU and hospital were also lower with intensive insulin therapy. But as I mentioned, the most important or the primary outcome, the in-hospital mortality was not different between intensive insulin therapy and tight glucose control versus a conventional insulin therapy. They also found that the in-hospital mortality was lower in patients who stayed in the ICU for longer than 3 days. So in this subgroup of patients who stayed for longer than 3 days in ICUs, the in-hospital mortality was lower with intensive glucose control. But paradoxically, the mortality was higher in patients who stayed for a duration of less than 3 days in ICU. But these were, of course, not the primary endpoints. The in-hospital mortality, the primary endpoint was not different between the two groups. And then N6 nice sugar trial. The study was conducted across Australia, New Zealand, and North America. Patients were randomized to receive intensive insulin therapy to maintain blood glucose levels in the intensive glucose control arm between 81 to 108 milligrams per deciliter, or a conventional target of 180 milligrams or lower. The study included 3,054 patients in the intensive control arm and 3,050 patients in the conventional arm. So this is, in fact, one of the largest randomized controlled trials in the field of critical care medicine. So their primary endpoint was death from any cause at 90 days. And they found that mortality at 90 days was significantly higher with intensive control compared to the conventional control, 27.5 versus 24.9%. The treatment effect did not differ between medical or surgical patients. One of the important findings was that the incidence of severe hypoglycemia, defined as a blood glucose level of less than 40 milligrams per deciliter, was significantly higher in the intensive glucose control arm compared to the conventional group. It was 6.8% with intensive glucose control versus 0.5%, and there was a significant difference between the two groups. There was no difference in the duration of mechanical ventilation, hospital stay, ICU stay, or the requirement for renal replacement therapy between the two groups. So this large RCT, a real-world study, you could say, across a heterogeneous population of critically ill patients, demonstrated possible harm from targeting intensive glucose control and a tight control of glucose levels.
So thanks, Dr. Jacko. So I guess Nice Sugar was definitely a landmark trial which challenged the dogma which was established after the LUEN-1 and LUEN-2 trial. Now, the criticism of LUEN-1 and 2 trial, where there were single center studies, and the mortality benefit that was seen in the first two trials was probably related to very well-trained staff, very well-protocolized management of glycemic control in that one particular ICU. And I guess the generalizability of that protocol was obviously quite questionable, and the training of the staff can be quite challenging in different parts of the world. So Nice Sugar definitely challenged the notion of tight glycemic control in critically ill patients. Having said that, Nice Sugar trial also had a lot of drawbacks. Now, one of the major drawbacks was that in some certain subgroups, actually Nice Sugar trial showed the mortality benefit in tight glycemic control. For example, trauma subpopulation where the odds ratio was 0.77, and also patients who were treated with systemic glucocorticoids, there was a demonstrated mortality benefit with intensive glucose control compared to conventional or liberal glycemic control. Another important drawback of nice sugar was there was no information available regarding premorbid glycemic control, diabetic status of the patients. So obviously it was very difficult to see what happens if the patient was diabetic prior to enrolling into the study. And that's what normally we see in our ICUs now, that 25% of our population is already diabetic before they come to intensive care unit. So that population can be very different than the patients who are non-diabetic. So I guess that's the kind of nice segue into some of the controversies that we are going to discuss today. So the first one to discuss is about what's the kind of ideal time spent in target range, because within the 24 hours, even with implementation of tight glycemic control or conventional glycemic control or liberal glycemic control, if patient spends only few hours out of 24 hours, that might not be sufficient. So Dr. Checker, what's the kind of evidence around the time spent in target range around the glycemic control?
Yeah, Swapnil, that's a very important question indeed as to how diligently do you maintain blood sugar levels and how often they spend time within the target range. And could wide variations in blood glucose levels lead to adverse outcomes? That's a very important question. And the second question is the duration of time within the target range an important factor in deciding outcomes with tight glucose control? We have some observational studies in this regard. In one of those, the maintenance of a blood glucose target was between 72 to 136 milligrams percent. And this level was maintained for more than 70% of the time. And when they maintained it for this long, for a longer duration of time of more than 70%, survival was better. Reduced organ function was observed when the duration of time within the target range of blood glucose was more than 50% in the same study. More than 80% of the time within a target blood glucose range of 70 to 140 milligrams percent in another study was again associated with survival among non-diabetic critically ill patients in yet another observational trial. So these studies, although they were observational studies, do indicate that the consistency of maintenance of blood sugar levels for longer duration of time would be a very important factor. It is also important to note that the time spent in the target range was a low 31% in the NICE sugar trial compared to 53.1% in the LUEN-1 trial. So that may have been a factor which could have decided different outcomes between these two studies. So at the end of the day, the duration of time with maintenance of blood glucose in the target range may be an important determinant of clinical outcomes.
Thanks, Dr. Chacko. So obviously the exact answer we still don't know. And I guess that's partly because the way we monitor blood glucose levels in ICU, often the practices are, in Australia at least, we do 4-hourly BSL monitoring in ICU patients, even when they're on rapid infusion. So we don't do hourly BSL monitoring once we have kind of stable sugar control. And I guess that makes life a little bit harder to then see how many patients remain in that glycemic target and how long. So I guess that's one of the other questions to then think about. Is continuous glucose monitoring is useful compared to intermittent blood sugar level monitoring? And is there any evidence to support continuous glucose monitoring in order to establish how much time patient had spent in that target glycemic range?
Intermittent measurement at set time intervals very often results in wide fluctuation in blood glucose levels, as we have seen in many of these studies, and invariably result in unidentified episodes of hypoglycemia, which may, of course, lead to adverse clinical outcomes. Continuous subcutaneous glucose monitoring systems measure glucose levels every few minutes, and it might enable more efficient control and thereby reduce the risk of hypoglycemia. In a study by Maisu et al., they compared glucose control using a continuous subcutaneous glucose monitoring system with conventional intermittent point-of-care measurements. And they found that the time in the target range of blood glucose between 144 and 180 milligrams per deciliter was significantly longer with continuous monitoring compared to intermittent measurements. It was 51.5% versus 29%. The mean glucose level and the incidence of hypoglycemia did not differ between the two groups. However, the duration of hypoglycemia was significantly lower with continuous monitoring, obviously, because if you monitor blood glucose levels continuously, you get to know if your patient becomes hypoglycemic and you can quickly act on it rather than wait, which might lead to an unduly prolonged period of hypoglycemia. So this study suggests that continuous subcutaneous monitoring may enable better maintenance of blood glucose within the target range with fewer episodes of hypoglycemia. So at the end of the day, it's very important to maintain blood glucose levels in the target range without drifting towards the hypoglycemic range. And continuous monitoring of subcutaneous glucose levels might enable prevention of hypoglycemia most of the time and thereby probably reduce the harm resulting from unnoticed hypoglycemic events.
Yeah, no, thanks, Dr. Chakos. So obviously the problem, the continuous glucose monitoring, it's expensive. And so far the trials have not shown any mortality benefit. And again, it can be very cumbersome and it can be quite challenging to have continuous glucose monitoring in ICU when they have attached to so many other monitorings. The third important question in this whole glycemic control controversy is about patients who are diabetic versus patients who are non-diabetic. And should we be aiming for different sugar levels in these patients based on their pre-ICU admission glycemic levels? So with regards to this aspect of controversy, what's the evidence out there?
As you rightly suggest, a more liberal target range may be appropriate in diabetic patients, and it has been shown to be associated with reduced mortality in a before-after study. So in diabetic patients particularly, it may be important not to drift towards the lower blood glucose levels, which might actually lead to harm. On the other hand, in critically ill patients without pre-existing diabetes, in a retrospective cohort study, hyperglycemia was associated with increased mortality. So it works both ways, depending on the baseline blood sugar levels or whether you are diabetic or not at baseline. And in another retrospective cohort study by Kwan et al., they evaluated the frequency and outcomes associated with relative hypoglycemia in 1,592 critically ill diabetic patients. Relative hypoglycemia was defined as a blood glucose level below 30% of baseline levels as estimated by the HbA1c levels. And they found in this study that the 28-day mortality was significantly higher among patients who developed relative hypoglycemia. Besides, the incidence of absolute hypoglycemia, blood glucose of less than 70 milligrams per deciliter, was significantly higher among patients who experienced relative hypoglycemia. Thus, the optimal target range may vary between patients with and without diabetes, and you would need to tailor it to the clinical situation. Particularly, diabetic patients may be more prone to the harmful effects of relative hypoglycemia.
Thanks, Dr. Chakos. So one of the other study was that you mentioned, the before and after study was the SUET trial, a SUET trial, which was a prospective open label sequential before and after study in ICU patients with diabetes. And it basically compared the impact of liberal strategy, which is 10 to 14 millimole, versus conventional, that is 6 to 10 millimole glycemic control. Now, this trial included 350 consecutive patients with diabetes who received liberal control strategy with a pre-intervention control population of another 350 consecutive patients with diabetes who received conventional glucose control strategy. Now, this trial found that liberal glycemic management decreased the insulin therapy requirements and it lowered the glucose variability. However, it did not show any mortality benefit. And also it did not found any evidence of harm from the liberal glycemic management in any patient subgroup. Obviously, this was not a randomized controlled trial, and that's why obviously generalizing these results can be quite challenging. But I guess over the period of time, we are realizing that diabetic patients are different to non-diabetic patients, and they might need a personalized approach or individualized approach of glycemic control. And one of the ways to do that is to measure HbA1c levels in patients who are admitted to ICU to understand how their blood sugar control was before they were admitted to ICU. And based on that, we can probably potentially titrate the glycemic levels when they're in intensive care unit. So is there any evidence to suggest that targeting the glycemic levels based on pre-admission HbA1c level changed the outcomes?
Yeah, this study we in fact discussed last week, the controlling study, which compared a target of 180 milligrams percent compared to blood glucose target based on the usual glycemia. Usual glycemia was calculated based on the HbA1c level. And in the individualized control group, based on the usual glycemia, the blood glucose target was set to the usual glycemia level plus 15 milligrams per deciliter or less, and a target range of 111 to 217 milligrams percent. While in the conventional, the blood glucose level was maintained at 180 milligrams per deciliter or less. The controlling study was maintenance of glucose levels in the usual glycemia range versus the conventional level of 180 milligrams per deciliter. The blood glucose targets were maintained throughout the ICU stay. The primary outcome was all-cause mortality at 90 days. And this particular study did not show a significant difference between the individualized versus conventional control groups, 32.8 versus 30.5%. And no difference was observed neither in the other clinical endpoints, including the 28-day mortality, the ICU length of stay, the duration of vasoactive drug support, mechanical ventilation, and renal replacement therapy. And they found on post-hoc analysis that the 90-day mortality was higher among non-diabetic patients in the individualized control group based on the HbA1c level. The 90-day mortality was also high in the individualized control group with surgical patients and patients with HbA1c levels of 5 to 6%. So although this study started off with premise that targeting blood glucose levels based on the baseline levels according to the HbA1c levels might actually result in better outcomes, it was unable to prove as much.
Yeah, that's correct. We discussed this trial quite depth in last episode. So those who want to listen to that podcast, you can access that episode via iTunes or on the website www.critcareedu.com.au. Now, importantly, one of the challenges with the HbA1c level, and it basically reflects the poor glycemic control over the last 3 months' time. But one of the challenge in critical care population is they often develop stress-induced hyperglycemia due to the phenomenon called as insulin resistance. And often that tends to get better as the underlying pathology gets better. And often if we use the one fixed target for glycemic control throughout the patient's ICU length of stay, that can actually potentially harm the patient, mainly because the insulin resistance tend to improve during the length of stay. So I guess at the moment, there are a lot of uncertainties and a lot of unanswered questions around how we should approach glycemic control in patients who are admitted to intensive care unit. Also, another special population to discuss is neurointensive care population, especially the traumatic brain injury. And at the moment, all we know that hypoglycemia and hyperglycemia can lead to secondary brain injury, and that therefore should be avoided in these patients. And I guess so far, we don't have any robust data in this subset of population either as to what's the kind of ideal target in this subgroup of population, knowing whether they had previous history of diabetes or not. So many uncertainties and unanswered questions at this point of time. But it might be safe to say for time being conventional glucose control strategy to keep the sugar levels between 6 to 10 millimole per liter is safe in most of the critically ill patients. And there might be a role of personalized or individualized glycemic control in certain subgroup of patients. However, we need a large randomized controlled trial to prove that benefit. Any final thoughts, Dr. Chekko?
Certainly, as we discussed, the Leuven studies held a lot of promise initially in the early 2000s with diet control. But unfortunately, it hasn't really lived up to the promise with the SUET trial, which is a real world study in this kind of circumstances that you come across every day in your ICUs. It did not show any benefit with diet control. Not only did it not find any benefit, it showed that hypoglycemia may be much more common if you aim for too tight blood glucose levels, and that might actually, in fact, lead to increased mortality, as we saw in the SUET trial. So aiming for too tight a control might actually be harmful. And this may be particularly true in diabetic patients who are more vulnerable to the adverse effects of hypoglycemia. Even relative hypoglycemia may be harmful in diabetic patients. So that is a subgroup of patients in whom you need to be particularly careful not to let the blood sugar levels drift down to low levels. Even relative hypoglycemia can be quite harmful. And the other thing to look at is the time in the target range. The more consistently you maintain blood sugar levels, clearly it may be more advantageous and the clinical outcomes may be better as well. And towards this, continuous measurement of glucose levels may be one of the interventions in the future. It is being done in a limited scale even at this point of time. But perhaps when it comes to more widespread use, we may be able to control blood sugar levels better, prevent hypoglycemia, and prolong the time in the target range. But until then, of course, we would, in your average ICU, where patients of all kinds of heterogeneous patient subtypes, you stick to a conventional level of, say, 150 to 180 milligrams per deciliter and not try to lower it further to a tight glucose control regime.
Yeah, that's correct. So I guess the glycemic control is quite different to other interventions in ICU in many ways, including that it is highly dependent on the chosen protocol and training of the staff who is implementing that protocol. Also, glycemic control is a continuous intervention rather than a one-off event, such as, for example, prescribing the aspirin for MI. And that's why it's important to maintain the quality throughout the process of patient care, where we aim for normoglycemia, and that's very crucial. And I guess because of the complexity of managing blood glucose during the course of critical illness, as I said, we definitely need a large randomized control trial to address all the controversies. So thanks again, Dr. Chekko, for your time. We'll be back in weeks' time with another controversy in critical care. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.